would you seek out a trichologist for its effects on hair? A lot of people are interested in this for. Would you seek out a urologist for its effect on prostate cancer, BPH? Would you seek out an endocrinologist? Would you seek out an embryologist? Would you seek out an endocrinologist? Would you seek out a dermatologist for its benefits in the skin, an ophthalmologist for its potential effects in the eye? Would you seek out a cardiologist for its benefit on cardiac remodeling and LVH, ventricular hypertrophy? How do you get a balanced approach to this? Or should we just
I'd ask my family doctor for a referral to each of those specialists to talk about using dutasteride.
I'd be interested to see what various experts have to say, other than ourselves, I guess. So who would you seek out? Would you seek out a trichologist for its effects on hair? A lot of people are interested in this for. Would you seek out a urologist for its effect on prostate cancer, BPH? Would you seek out an endocrinologist? Would you seek out an embryologist? Would you seek out an endocrinologist? Would you seek out a dermatologist for its benefits in the skin, an ophthalmologist for its potential effects in the eye? Would you seek out a cardiologist for its benefit on cardiac remodeling and LVH, ventricular hypertrophy? How do you get a balanced approach to this? Or should we just
I'd ask my family doctor for a referral to each of those specialists to talk about using dutasteride. Or I would just go to a family medicine specialist who knows a lot about all of those things and the drugs.
That's interesting. And I think that's a good example of why it's so difficult to have a balanced approach for this drug. A lot of times when you do the specialist ping pong, where you go and someone's on a medication and it's having a benefit in one system, and that specialist strongly wants you to continue that medication because of its benefit in their system. And then the other specialist does not want you to continue it because it's having a detriment in that system.
This reminds me of when I used to work the cardiology floor. The cardiologist and nephrologist would go back and forth.
Classic.
Cardiologists would love the Lasix, and the nephrologist, up to a point, will tolerate the Lasix. And they're like, okay, you got to stop doing this. I know it's working, but that's an interesting tug of war that happens there. So one of these experts, actually, they were both urologists that were on the Drive podcast with Peter Attia, who's a medical doctor as well. Dr. Kara, I believe, made the appearance first, and he's a urologist. I believe he also has a master's degree in public health. And I found this to be a really enjoyable podcast for the portions that I listen to. A couple of good things, like he mentioned CAG repeats, which outside of our clinic, I really haven't seen people that are aware of this or are testing for this. So
maybe he listened to the Gillett Health podcast we did on that years ago.
He was actually doing these CAG repeat testings when he was a fellow, from what I recall. So one of the early users, I don't know if he's using it in practice now, but pretty interesting. He also does some research on patients who have this association with taking finasteride and then developing post-finasteride syndrome. So certainly more research does need to be done in that area. It's nice that he is accepting of that, because you have some people, and in fact, I think the American Urological Association doesn't formally recognize post-finasteride syndrome. So you have a lot of urologists and physicians that say, oh, this is just 100% psychosomatic. And then you have others that are saying, and maybe he falls a little bit into this category, overestimating the prevalence of it. Another good thing was that he discussed tadalafil as a ED preventive.
He was a tadalafil enjoyer. That was definitely good to see. Yeah. And we've talked about many of these same things. The interesting thing that we've seen, not just with this physician, but with many, is comparing the incidence of side effects from finasteride to the incidence of post-finasteride syndrome.
Yeah, in his response, because I think Peter Attia was asking about what's the ballpark number? How many people are getting a long-term issue from this?
Yep.
And he said it's above 5%. So that would mean, based on last year's prescriptions, you have about 125,000 men with permanent sexual dysfunction from finasteride. It seems like a stretch that would not have gained some traction up until this point.
Yeah, I could see 10,000, over 100,000. It's kind of hard to say. Now, keep in mind, most of these men that were started on finasteride had no baseline labs taken in regards to DHT or testosterone or certainly progesterone or pregnenolone or their progestogen pool, or certainly not CAG repeats either. But I guess the takeaway from this is it's good that he's discussing PFS, but it's important to say we really don't have a good idea of what the incidence or prevalence of PFS is. We just know that with certain treatments, it tends to get better, but many of the times there's a question mark of what was the preceding hormonal status or the preceding sexual health status of individuals that have PFS.
Yeah, I mean, a great case would be someone who thinks they have post-finasteride syndrome, and it turns out they have a microprolactinoma that's causing their marked sexual dysfunction. So it's not always the finasteride that's causing this. Mm-hmm. You have to dig deeper, do kind of a full workup, just like you would for any other patient who is like struggling with sexual function. Maybe it's not the finasteride, maybe they have, a 70% blockage in their coronaries, and then they have, plaque throughout their entire arterial system. So there's a lot of different things that can be at play here. You can't just say, oh, well, this happens. Like, post-finasteride syndrome is definitely a zebra, and there's a lot of things that are more likely to cause sexual dysfunction than finasteride.
Yeah.